Okay.
Go. So I'll hand over now for Kevin to deliver his presentation.
Thank you, Vaughn. Thank you, everyone, for coming along to join us today, and I suppose giving up some of your time today. And I hope whatever you're having for your lunch, that you're having something that you're enjoying, and that's nutritious and bon appetit. So what I am going to talk about today is drawing primarily on one of the projects that we worked on, which was funded by Wellcome, and it essentially was looking at organizational interventions in the NHS, so organizational well-being interventions in terms of supporting staff well-being. So that's what I'm going to be primarily focusing on. And the whole reason behind it, I do a lot of work as a psychologist. I would say it's kind of ironic over my career. I've become less focused on the individual and much more on the system and the organization and the context that they're situated within, recognizing that actually our context influences how well we feel, the quality of our working life, and therefore by extension our health, and therefore we need to be looking at a lot of the contextual factors in terms of supporting staff well-being. We know that healthcare workers in the UK and certainly around the world as well are particularly struggling in terms of working conditions and the corresponding effects of well-being, and that's kind of the context behind this setting. So what I want to do is go through a couple of models, so some of you might be familiar with aspects of that, talk a little bit about the project, give you some of the examples that we've come across, and reflect on some of the implications of that work. So briefly, we know that obviously we spend a lot of time in work, and research is increasingly clear that our working environment has an impact on how we feel and in terms of our health. Some of you may be familiar with this, the work by Will Fleming at Oxford, a report, and then later on a paper. But in this one over here, looking at a national data set of 143 organizations, nearly 30,000 workers, and essentially looking at aspects of the working environment, aspects of the individual, and what was being done within those organizations in relation to health, coming to the conclusion that actually interventions which focus on the individual, so things like mindfulness, like resilience training, coaching, well-being apps, no better off when it comes to a number of different subjective well-being indicators. So that obviously is of concern, because often when we talk to organizations and we say, well, how are we supporting our staff? Then most organizations will say, well, we've got comprehensive well-being strategy, well-being offering, and often it will include aspects such as what we see on the screen in front of us. The same study also unpacked, which actually mirrors a lot of the research that we see, that workplace factors, so essentially how work is organized, designed, managed, has an impact on our health, our well-being. So over here, more specifically, being bullied, time pressure, discrimination, strained relationships had a much stronger impact on these well-being outcomes. And therefore, the conclusion that actually what we need is we need to think about its staff interventions, not just at the individual level, but actually looking at improving the quality of the working environment of individuals. So things like having appropriate training, having control about when we have breaks, having voice, having fair pay, promotions, flexible work, and good collaboration. All of this we see also in the wider literature being strongly associated with better well-being. If we look at some other research, this one here looking at doctors specifically, this is a meta-analysis, so a summary of 19 studies. And when it comes to burnout outcomes, so Panagiotti and colleagues were interested in actually, can interventions reduce burnout symptoms among doctors? And what they're also interested is actually making a distinction between interventions which focused on the individual, so things like mindfulness, psychoeducation, so self-confidence, communication, exercise, in comparison with interventions which focus more on the organization, so things like having control over workload, having control of about when you work, communication, teamwork, leadership aspects of that. And what the meta-analysis demonstrated, well, the good news is that at the end of the day, overall, interventions had a beneficial impact. And we see this with this green bar over here in terms of the reduction of burnout symptoms over time. But when we distinguish between the two levels, this is individual and this is organizational level, we see that actually organizational directed interventions have a far stronger impact when it comes to health outcomes. So in this case, burnout complaints. And again, this mirrors what we see in the wider research literature, that actually if we're able to address issues at source, then what we're doing is we're taking a more preventative, more proactive approach. So it's not just about helping individuals manage their working environments, but actually in many situations, we're mitigating the risks, the health risks that individuals are exposed to. And therefore, we see not only a larger reduction in terms of, improvement in terms of health outcomes, but actually that this is often more sustained over longer periods of time because we're helping, address what the underlying issue is over here. So the conclusion really is that we need better quality working environments. So we need better working conditions. And the question then is, well, what does this look like? And I just want to quickly provide an overview of two frameworks. So one is known as the job demands resources model. Some of you may be familiar with it. I'm not going to turn this into an academic lecture, but quite briefly, we talk about actually the working environment having aspects which are demanding to us. So things like, our workload, how much so being bullied in the workplace, conflict in the workplace, time pressure, and so forth. And then we have resources in our working environment. So how much support we have, how much feedback, how much control, how much autonomy we have. And to put it quite simplistically, what we have to be doing is trying to reduce the demands that we have and increase the resources that individuals have in the working environments. And the reason for that is because demands, and the research literature is quite clear, predominantly associated with poor health outcomes, so things like burnout, symptoms of depression, anxiety, and so forth. In the context of healthcare, that's then associated with patient care, but in other industries, we see that that's basically associated with a number of different performance outcomes as well. The flip side over here is that actually job resources, so things like support, having control, having autonomy, voice, fairness in the workplace, is associated with better um, um, manifestations of well-being. So things like work engagement, like motivation, job satisfaction, and in turn, this is then associated with better performance outcomes over here. So really, the point is that actually we have to reduce demands, we have to increase resources. I'm not saying who we are as individuals doesn't matter because individuals who have got more resources, if you're more optimistic, if you are more confident, if you're better at managing your emotions, you are more likely to be better able to look for resources and craft your a more conducive working environment. And so really what we see over here is a need to support the individual over here, but also then actually more importantly, manage organizational factors in terms of resources and demands. And here's just a meta-analysis that we published a couple of years ago, looking at longitudinal data among doctors, where we were able to demonstrate that actually demands predominantly associated with emotional exhaustion, which is burnout, and that then has an impact on clinical care, which of course in the healthcare context is quite important. A second framework, just briefly, and that kind of builds upon what we talked about, is we talk about organizational factors, we talk about context, we talk about different layers within an organization. And a very useful way of looking at this is actually something known as the igloo model. So actually we talk about supporting the individual, but also the group, leaders in the organization as well, but also what's happening outside the organization, so the overarching context over here. So again, what's quite useful often is when we say to an organization, yes, you say you have a comprehensive staff wellbeing offering, but actually, what are you doing? What are your activities? And often when they map them out as an activity, they typically sit at the individual level. And there might be some things at the group level, maybe something at the leader level. But really, again, when we talk about comprehensive approach, what we want is activities across all of these different levels, because the intervention has to address whatever the demand and whatever the resource might be. So that's from a more academic perspective. And I guess people would then say, well, it sounds great on paper, but is this possible? And is this possible in the context of, say, the NHS? Demands are really high, resources are non-existent. And that's essentially where this project comes in, because what we wanted to do was look for examples of organizational interventions that have tried to improve NHS staff well-being. And in doing so, to try and understand, how do they look at demands? How do they look at resources? What are some of the things that they've done to do that? And in doing so, then what are the barriers and facilitators of success over here? I'm not going to go through the methodology in too much detail, but essentially what we have is we had interviews across 20 interventions, which we identified. We have a report, and I'll give you the link to that at the very end. And we covered 12 of these interventions in a lot more detail over here. But just briefly, what we have over here is these are some of the titles of the interventions that we looked at over here. And if you have a quick scheme of them, some of the things which might come to mind is actually that at surface level, they might not look like well-being interventions. And that's one of the interesting points that we pick up upon, is because actually when we talk about better working environments, sometimes they might come just because people want better working conditions, or they want to fix underlying issues, or performance-related issues in the workplace, or improve processes, or structure in the workplace. So it might not actually be necessarily explicitly because of a well-being point over here. We see in the bottom left over here, a range of interventions around flexibility aspects of that, but we see a whole range of different things around fatigue management. I'll cover this as an example later on. Employee investigations, which I'll cover later on as well. But a whole number of different interventions over here around improving processes, essentially, in the workplace. And there's a very simple one over here. This was MDT meetings, so multidisciplinary team meetings. And it really is quite a simple activity by putting, long story short, by putting in meeting guidelines. They brought what was previously an MDT meeting, or MDT meetings which people didn't want, which people didn't like, which on average lasted about 7 hours, a whole working day. And they brought it down to about 3 hours by being clear and being focused, actually saying this is what this activity is going to be about. And when you think about it, it became an activity, a meeting which people were frustrated about, to something which actually they found developmentally useful as well. Because while they were talking about fewer patients during this meeting, what they actually were able to quantify is that they were actually spending more time talking about each patient that they brought to the meeting. So the quality of the interaction also improved as well. So one of the things that we wanted to do was, with our 20 interventions, was to kind of map them to the demands, to the resources, but also across all of these different levels over here, just to have a better idea of what actually people are doing in trying to support interventions over here. This one slide tries to pull it all together. I'm just going to give you a whistle-stop tour over here. None of these interventions, because one of the things was all of these interventions in a way started fairly organically, naturally within those settings. It wasn't a case of external academics or consultants coming in saying, let's do this and here's a model, but it was more about actually inherently coming in, or individuals coming together and saying, we have an issue, and that's how do we try and address this, and how do we try and improve our working environment over here. So this is more about us retrospectively trying to map what they did through to our frameworks. And you can see that, there are activities done across all of these levels over here. At the individual level, primarily focusing on increasing resources, that's unsurprisingly. So about improving people's understanding of well-being, about improving their technical and career competence. So, if you improve people's competence in their work, they're becoming better skilled, then that helps them better manage some of the workload aspects of that. And then some things around psychoeducation, so improving their psychological skills, confidence, and so forth. So we're not saying that, not working with individuals, that we shouldn't be working with individuals, but that there is a role to play in certain settings over here. At the group level, so a lot of work around trying to help groups reduce the demands that they face. So often it's bringing groups together to say, how do we better manage our workload? How do we support each other in terms of managing emotional demands, but also challenging some of the demands that as a group we place on each other. So things around stigma, for example, but also conflict in the workplace over here. So bringing together ways of saying, how can we do this more efficiently? How can we reduce processes which actually are redundant? So, the MDT meeting as an example before, as part of the work that they were doing, is they were saying we were being asked to fill out these forms, and what was the point in filling out these forms? what happens to them? They learned, it ended up sitting in a SharePoint somewhere. Does anyone ever actually look at this? No. Is this actually part of our governance processes? No. So can we get rid of it? Actually, yes. So in doing so, you're already starting to have the conversation to say, yes, how do we reduce workload? Essentially by starting to remove some aspects which perhaps are not relevant to the work that we're doing. We try and increase resources at group levels, so through discussions, through activities, empowering teams to take control, to have autonomy, improving the clarity of individuals' roles, and essentially trying to enhance a positive team climate. For leaders, we want to reduce the demands, the expectation that leaders have of their staff. So essentially, actually, um, and often where these demands might be unrealistic. So one of the other interventions, which was in with dietitians and the pressure which leaders were placing on individual dietitians to complete tasks during their appointment times. So one of the activities they did was they got a line manager to sit down and to try and work out how long it took to work out each protocol or paperwork that on average a dietitian would have to complete when they assessed a patient. And what they realized is that, just by doing these activities, it took up more than 3/4 of your average appointment time, which meant that actually at the end of the day, before you could even ask really someone, why are you here to see me and how can I help you? You've only got a quarter of your allocated time. And that was kind of a pin, a light bulb awareness moment for line managers. Say, actually, there is a problem over here that it's not feasible for our staff to complete the work that we're asking them to do. And that then starts a basis of saying, well, what can we do to improve in this situation? Increasing resources among our staff, so among our leaders, are improving motivation, having role modeling that comes with that, developing their competence. That's quite important as well at the organizational level. So it's bringing then stakeholders together to look at how do we reduce workload, um, physical demands as well, and then a lot around increasing resources. So how do we look at increasing staffing levels, which is a big part over here, and whether that's more creative use of funding, looking at different ways of trying to increase staffing levels, improving collaboration, learning development, improving staff voice and control, autonomy at the organizational level as well. All these are examples that we've come across over here. We weren't expecting to find anything at the overarching context because these are things which happen outside of the organization. But we were surprised actually to find that there were examples of people actually working outside of the organization to bring learning together, to share resources as well, to say we haven't got funding within our organization. So how do we pool resources across organizations, tap into funding that might come perhaps from royal colleges, that perhaps might come from unions to support some of the activities that we're doing over here. And how do we also lobby in terms of guidance, legislation, policies to try and improve our working conditions over here? What I wanted to do was to just talk you through two examples over here, just to kind of bring this to light over here. One was an example of trying to address fatigue in a maternity division up north, so one of the largest maternity divisions over here. So unsurprisingly, the nature of the work, men's fatigue is a big concern over here. And what they wanted to do was actually to say we want to approach this from a more systemic perspective and not just say, well, fatigue is the responsibility of the individual to try and address over here. So they've essentially brought um, um, created working groups to try and say, how do we create a better culture in terms of supporting colleagues when it comes to managing fatigue over here? So a range of different activities across those different levels. And what was quite nice for us was this was one intervention we were able to map across all of the 5 levels over here. So as unsurprisingly as you see in many contexts in many other NHS trusts, still activity focusing on the individual level. So psychoeducation, that the psychologists come in to work with individuals to increase awareness around, the risks of fatigue, how you better self-care, the importance of power nap, the role that that can play, circadian rhythms and aspects of that. But they were quite aware actually that we can't just leave it at that level. We need to look at all of the other things as well. So at the group level, they had numerous different facilitated sessions around how work processes can be changed. So I'm not a clinician by background, But one example that was shared was, looking at, in some situations a patient might present and they would need a cesarean section, and that might be very acute. It has to happen straight away. But actually, what they were doing was inviting conversations to say, for members of staff to say, how was fatigue impacting them? So to give permission to people to say, actually, I'm feeling tired. Is there a risk potentially to us as staff members, but also particularly to the patient as well? So in some situations, there might be a situation, a situation where someone might say, or a team might decide that actually what we could do is we could push a cesarean section back by 1 or 2 hours potentially, and wait for the next shift to come in, because then they're better placed to deal with that situation. So by delegating that workload, it's the best outcome for the patient. It's also the best outcome for the team. But when the next shift comes in, they're aware of what's happened because they're part of this discussion over here. And they know why this has happened, and they know that actually this is in the context of fatigue, and that they also might be in a similar position in the future where they might be delegating tasks to next shifts as well. But part of this group discussion is also then fundamentally creating an environment where people are talking about actually what impact fatigue has on me, on us, and why this is important. And in doing so, also challenging some of the assumptions that leaders have, because what came out was actually that the matron basically was saying that a good midwife does not get tired. So if you've got your leaders, your managers in that context holding those mindsets, then you can have all the individual training that you want. You can tell individuals to say, take a break, admit that actually when you are tired. But if you're concerned that your line manager is going to judge you because she's saying that a good midwife does not get tired, then actually that is an approach, and that's a mindset that has to be challenged by other leaders in that context as well. So again, senior members of staff over here, role modeling, taking breaks, self-rostering as well. At the organizational level, they got funding to revamp rest facilities. It includes sofa beds over here, but also actually managing to get additional funding to rota an additional anesthesiologist on call to provide cover, because colleagues were saying, well, it's great having all of that, but if we haven't got the cover, there's no way we're going to be able to take breaks over here. So the success and improvements that they have in terms of working culture and managing fatigue actually led them to use their learning to as part of efforts to lobby for fatigue legislation at Parliament as well. But you see for here an example like fatigue, which is something which many places across healthcare are struggling with. And often when we talk about how are you doing, how are you supporting fatigue in your environment, well, they're saying is we've got an app, we have a webinar, we have a training course, we have an online module that teaches people about fatigue, and you do that, and that's how we do it. Or alternatively, they might even say, actually, we've got sofa beds, we've got money, we've revamped our rest facilities. But if people are saying there is no time to take breaks, if people are saying my managers will judge me if I take breaks, if people are saying the work doesn't allow me to take breaks, then actually all of that is redundant over here. So what we're saying over here is that there are things that we can and should be doing, is recognizing that activities should happen across these different levels over here. Another one